We are very close to that. Simulated we use for teaching, learning. We can use for assessment also.
Technical aspect will be more covered in standardized compared to.
So when we want to have final exams, sir were telling about the final exams, university exams, standardized questions will be learned. You have standardized everything for every student. That's the only difference you will find. Okay, there's still a controversy, debate going on, difference are there or not. But ultimately they are both same. But when you have standardized them, it's better, it's very friendly to use them in the assessment. Okay, so that difference will come. So you're very closer to that. So it means simulations we can use both ways. Okay, when you have standardized them, they are more apt for the assessment. So objectives of a SP program in your institution will be to improve clinical and communication skills, ensure competency-based training and assessment, promote safe, repeatable learning experiences, something like that. So benefits of using SP which are reported right now. Realistic clinical encounters, you can actually build up that. Feedback from the patient perspective, as sir told you, is very important for the student. Feedback, you will get many times feedback. Today also, sometime here and there. Yesterday I gave some feedback to hotel people. But how people, whether they accept your feedback, that's very important. Here acceptance from the simulator patient, because they feel they are related to that. The students who are there, they accept to that more. Controlled and consistent scenario that will take care of your reliability issues, making the assessment more authentic. Practice of rare or complex conditions. Sometimes you want to do that, where you don't get patients. Okay, that you can simulate. So those type of scenarios and benefits are there. SP in India especially, the effort started around 2000. And some, as I told you, some institutes are doing out in a proper way. Initially limited uptake due to lack of awareness and resources. CPME rolled out, boosted this program, sort of things. And now piloted in colleges with MEU simulation centers. Used in OSCEs, communication skills, ACCO modules are using a lot of that. Because when you want this scenario, how you feel like being a relatives of a patient. Easily you can prepare people to act like that. Slow but growing adaptation and UG and PG curriculum. And especially some colleges we have seen they are in the periphery. They are struggling with keeping the patient number even for NMC inspections. The percentage is very less. There it is very useful. In some other government institutions have a lot of patients. But again, new government institutions, the periphery, remote areas are not getting. Same way, some private are doing so many OPD, but some private they are heavily dependent on the education part only, but their patient number is very less. So there you can try to see how you have to use that. So presently in India, most curricula have changed to competency based, all health sciences, except dental. Okay, last 2 weeks before you have seen physiotherapy also changed into that and others. So all are blended. So now when we are talking about interprofessional health and simulated patients, we are all at the same level. It means it is easier to use now in the interprofessional sectors, which has come out. Dental is working on that, but right now their issue is shifting from council to commission. Okay, that is stuck up somewhere there, so that will be done. So when we look at these all roles, okay, sir has given principal set of Dr. Srinivasan has given you a mnemonic for this in the morning. Some of you are wondering what he is saying. Okay, so he was talking about these roles, which even students are learning about that. So here you will see how we are making them professional, clinicians, communicators, leaders. Heavy role of simulated patients. Your programs can actually address to all of that. So that way we will see that all these newer components which have come into that. ECE, there is exposure to clinical context. How you do simulated patients. You can't take your 250 class in first year to OPD. People are struggling with that. Okay? You bring simulated patients to your class. Okay? There you can see Parkinsonism. People can act out like Parkinsonism in physiology class. EC, then you have a neurologist coming into that. Our principal is neurologist. He comes for the EC class for that. So like that way, lot of opportunities are there. Integrated teaching you can do. So core component we will go after the T, and then we will build up how to build up with this program. So we'll break for tea for 20 minutes. So we come back at 12:05. Patients, initial components, the awareness you have to have in your institution, sort of some detailed discussion with the people who are going to act as simulated patients. Some of the items where we have confusion, we had some discussion on that. We are now going to this methodology, recruitment and training. We have discussed a bit about that. This shown you also scenario development, how you do that. That is common when you do for each simulation also. Faculty development which you need, training your own faculty. Because when you go back, you have attended a workshop, you see other people in the department need to be aware of that if you are running a program like that. Some assessment tool, and ultimately when you have a full program, how you do a quality assurance. So align with the curriculum which has come as already, we have seen that which competency to choose. Then 12 patient scripts, checklist for evaluation, some supporting documents you want to give to facilitators and to simulator actors. Everything is needed to be documented. Scripts are needed, which sometimes take time initially only. Once you have made them, only updates are needed into that. So these things are need to be developed. Involve content experts. Here sometimes we have not been trained like that for in education. For many of us, it might be first session you are attending. So there are some content experts only in the education or the higher courses who can help you with this development of scripts, checklist, supporting document. A lot of people are working on scripts. Doctors only I'm talking about, who are trained in additional courses in education. They make interview scripts, they make FGD scripts, they make scripts for the role plays and all that. Once they know what is the methodology, it's easier. It's not easier without learning the methodology how to make scripts. And remember, this all we are talking about that they have experiencing something, they register, analyze it, reflect onto that, apply that new experience. This is a learning spiral which happens in the simulated patients to the learners. A lot of theories are behind it. This is one of the major theory. Now, when you look at this component, when we talk about what I am showing you, okay, do you sure what I am planning to simulate it? By looking at this picture, you might have a various prospects or reflections on that. You are not sure why I have put it down, what was my objective. So what you are thinking is, you are getting a message from this picture. Cheating. Okay.
Practically something is happening and then projecting.
Okay, something is happening and they are projecting is differently. Here you have a non-cooperation.
Learning by doing by seeing.
Learning by doing by seeing. See from here.
Both of them trying to control.
Both are trying to relate to the SP program. Number one is, which I put up earlier also, very important. Why you are developing this program and each scenario? You should be very clear. Okay? So this is what we use in our conflict scenario. A lot of people come with various things. We say they are three siblings. Or this can be wife and wife sister. Most of you thought like cheating. Obviously, see, in our cultural things, those things come into our mind. But if they are not clarified here in the starting of your program, then these situations will make like that. This is a conflict scenario. Again, we use simulated. So we are talking about interactions with the patients also when they are conflicts. In all our healthcare system, these are the stakeholders. And today we are highlighting on patients, simulated patients. But it is impacting the entire system. The students are learning, faculty you are there. Once you have this program, cost effectiveness is there. You will see that. But remember, some part of central scale budget you have to allocate in the beginning to this. Otherwise, later on, very difficult to get money for simulated patients under different headings. Okay, so that is logistic component which comes into that. Already if you see in the new CPME, they have put up these components. It's easier for you. Many people say, can we use simulations in teaching? Can we use simulations in the assessment? So this is already very well documented, not only in the medical, but all the healthcare professional curricula which are there in India right now. They are also the same platform. You read those curricula, they are beautifully made. Medical was the first one to experiment, which has improved with the CBME 24, but others are beautifully made. Similarly, you will see the assessment methods. You are already doing OSCE, they are there. Reviewing reflection, direct observation, then you have a short case. That also in the simulation you can teach and assess. It's not only OSCE, remember, where you are limited to one aspect, one objective you take. You want to have some people say, no, I am in totality, I am not able to see. Then you have a short case and long case. There also you apply this principle. Very well these can be applied. Very good tool for learning and assessing those components. And in the teaching learning method, you don't have to struggle. In the CBME 24, it is given for which competency you can use simulated patients. Earlier this was the issue. It was taken care that when we are telling people to make central scale labs, we have to put it here also, where we use them. Earlier colleges were deciding department, there were a lot of issues coming, the way it was happening, it was very different in different colleges. Now at least you will listen. This, actually I just aligned with the student example I have given today morning. He was going, I said, what is the issue with the SDL? He said, sir, SDL sometimes we are given totally new topic. You see, you very right. Right now many people could not select topics for SDL. For example, I'm just diverting, but just to give example in relation to simulated patient. SDL topic should be where you are already taking 2 or 3 lectures. This is a continuous topic. Example, drugs in tuberculosis is taught in 1 lecture. We take 2 or 3 lectures in pharmacology. First lecture you do drugs, second, third lecture you don't take. Pharmacotherapy goes into SDL. It's not a totally novice topic. Only then discussion will happen. Exactly he told us that it should be a build-up a topic, building upon a topic. That was the issue. People were not doing. So this time when SDLs have been put into, you will see in your teaching learning method and the SDLs have come into that. Similarly, simulated patients. Now you can see the list and it is there. Learner doctor method, many colleges were struggling how to do that. Sometimes you don't have patients. Simulated patients in the early years, first and 2 years, year 1 and 2 you can use simulated. Then part 1 and 2 they are getting a lot of patients. Then they are into wards also maximum. So that is a good method where you can use simulated patients in our context. In fact, see, if you see avenues for different things, formal teaching, skills, attitude, practical teaching, they are very apt for simulated patients. Out of that you can just see which competency, and now that is also given. It means your job is easier, just see in the teaching learning method assessment where you have to use simulated patients. That's easier. Direct observation means simulated patient you can use that. We talked about this already today in the morning. Reliability came into point. Something we talk about validity when we say pick up the competency. Right? Feasibility is very important. Running a program needs feasibility. For example, attending half-day workshop, you go back to your institution, say I want to start a new program. What will be the reaction there? Back home is the institution. Which type of resistance you will be? Financial. First thing is financial. Your dean and administrator will ask how much money you need, what advantage you will get, why we should do as institutions. Because feasibility is very important. So that will need to look into that. Acceptability, you have started in your region. You are asking people to come. You are paying them to advance. Maybe some local politicians get involved. Why you are doing this? A lot of people like this happening. So cultural context comes into here. How are you looking at the cultural sensitivity of that environment, put up your program and the impact of educational element. If you start using simulated patient, what do you think will be the impact on your students in your institution? So suppose you are running patient, your more pool is there, everything is aligned, somebody else is managing, you as a doctor are not managing. You should actually concentrate more on intellectual component. You have managers or people who are managing this process. You have a requirement, you send requirement, you get simulated patients on that, a teaching learning order. So after 4 or 5 years, what would be the educational impact on your students of this phase? On their learning?
Definitely better than before.
They are better than before in what respect?
Identifying
direct
patients.
contact with the
Yes.
managers.
Identifying and interacting with patients.
One is identifying and tracking patients, one was here.
More competent skills, there will be more competent in skills.
More competent, especially in the skill part.
And the singer
So manages a process which they do not have interference, because you are sending lists, they are present, they can't enclose that part. That program is well set up, but you are running it for 4 or 5 years. What will be the impact on learning of your students? Skill part will improve as you go. They will be interacting better, they will be using all those steps which are there. My name is this, what is your name? Okay, can I do this, can I touch you, can I do this examination? Those things improve. Which some of them we have to, was already we are using skill lab simulations from 2000, maybe 19 was first year shaky, 20 onward we are regularly using them. And students are so well trained. I think presently our MBBS students, these batches, they know empathy better than many of the teachers. You tell them to write what is empathy defined in, what are the components, they are doing very well. Which we actually wanted, that they are lacking how to even talk. Because 90% of the cases against doctors are ultimately lack of communication. They don't talk. So that is a component which is coming up. So some of you are asking that they are rehearsing skills in the preparation for the practice reduces adverse events. Some of that, there are a lot of evidences now. Behaviors during simulator training predict actual practice. We have seen in these students. 18 batch was wondering, I have seen the actual interaction. 18 batch was telling them, what are you doing this? Why are you telling your name to the patient? They say, no, we haven't trained like that. So many outcome sessions, so many, then we have built up that into our subjects also. They start like that. My name is this, what is your name? So that becomes an actual practice. And this is competency. Definition of competency is habitual and consistent use of knowledge, skills, communication, affective domains, real values, other things. When it becomes daily practice, not that when teacher is observing. That becomes a competent person. Changing educational trends, which we have seen with the CBM. Changing healthcare scenarios, for example, team building. Your teams are working better in an acute situation. Patient of MI comes, how your team reacts to that. There is a trauma, how your team reacts to that. Your institution reacts to that. If your multi-specialty teams train together, you will see that difference. This is the typical scenario which you might have seen in many labs. Some of you are from here, you have a debriefing room here, just right? You have seen here. The biggest part you see time-wise is debriefing. Briefing takes less time. Actual scenario is also 7 to 8 minutes where you are using that simulated patients. Most of the learning will happen here. It means that you are using as a media only for learning and assessment. Rest of the things happen after. This is the simulation pyramid, simulation plan you are executing, actual simulation happening. Debriefing, where most of the learning happens, then transference of this to the actual patient encounters. This is what we are expecting. Let's take example of a simple skill. You want to teach a student. First you will tell these are the steps. ENT procedure, surgical procedure or any other procedure. You will tell which is the more knowledge part. Steps of any procedure. You can ask in a theory class. Then it becomes a valid line. Then you show them video. The same steps in the video. They observe a video. Then they do it with the simulated patients. They make mistakes, correct them, again do it, make mistakes and correct it. Then they go to patient. Now you can see their confidence and the patient safety, okay, which is reported every year. So this is a typical deliberate practice model which is used. Waterfall sports model, very commonly used here. Teacher's role is changing, but we are looking at everyone coming to this competent level from the world. Some will go to higher level. This is our idea that in the simulated patients, as we are observing them, we know how they are progressing. Then you can mark them. So that's why you have a logbook where you have to mark. You have seen to certify competency, how many times observed. We have to observe them at different times after giving them feedback, and they are correcting those steps. That's very important component. We miss them and we sign up one day on the logbook near the. Please use it. Only 2 competencies are certified. If you spend 1 week or 2 weeks with a student for a full 1 year, this is very helpful to them. And some of you are asking simulation, what we can be simulated. A lot of lists are there, what you can simulate. So those things which you can simulate are here. Everything cannot be simulated. For them, you use other teaching learning methods, other assessment methods. which are there in your components. Just to see when you have a list of these things, you want to put them somewhere, you can use a blueprint, which many universities are doing. I am talking about not theory blueprint, I am talking about now skills, practical based blueprint. Blueprints are there now for the MBBS, even our university we have made for the postgraduates also called blueprint on the day of examination, how exam will be conducted, percentages available for competency as well as method. So you know what actually is to be done. This is pulmonary medicine. Which competency, how much is to be done. Exactly here you can fit up. Now you can fit up simulated patients. Maybe in the short cases I am putting up the simulated patient. Since a postgraduate exam, OSCE also has more time, 50 minutes at least per OSCE station, you can also put it. Lot. So why we can do this? Because there is a lot of scope now. This is surgery. Something like blueprint. Many universities have made that. Because this is the first batch who is appearing in the postgraduate exams who are following APME pattern. This exam, this is now as per new paper 1, 2, 3, 4 has changed, titles have changed, blueprinting has come in. NMC has said universities to make these blueprintings. Based on that disease pattern in your area, you can make a blueprint. And on that day when you are choosing short case, 1, 2, long case or OSCE station, you can choose that for we are choosing, for example, MBBS. I want to see all these skills in an MBBS student on the day of practical examination. You choose cases, okay, maybe history taking, you are put one short case, and history taking one on the respiration, OSCE, I am putting this. This way, you are completing all the topics and the whole process. And this takes less time versus computational components. You can actually have more number of students in a lesser time, which you need in the MBBS. MD you have a lot of time, but blueprinting is better. So blueprinting, earlier I have shown you for the competencies. One was for the competencies. If I go back, it's also different. Remember that. This is for the competencies. This is for the methods. How the weightage is given, and this is for a particular day of clinical cases which you are putting up. Blueprinting for that, giving a weightage. Everyone is clear. Okay? You are not heavily dependent on one system or a long case. On the basis of that, you can decide. Further, in each subject, each day, you have decided, okay, this will be the case in each topic. Blueprinting can easily go up to that. You might be doing this already. Okay? In an informal way. This is the formal way to do that. So that everyone is clear. You have 3 or 4 days MBBS setup already ready. This is our blueprint day 1, 2, 3. Then you choose your patients how to do it. Case development also is a process which is it is like any case development, CBL or PPL. Similarly, in here, when you construct your case, you have to prepare your simulated patients accordingly. So you will think about chief complaints, medical relevant details, patient personality profile, because this is very important. Because on this basis you will make your script. Case checklist which is to be given to assessors as well as to the simulated patients, examining instructions, patient note to evaluate. So all this will be part of that. There are many methods how you make cases, relevant, realistic, engaging and challenging, content, structuring, what attributes and what to do with the process. Okay, we will not go into details of that. So I am showing you some examples of cases which have been developed. So how you, for example, this is the gout. What are the different components you will see? What are the overlapping areas? Because you will be making a script based on this for a patient who will act like that. Okay. So this way they will go into that. Example of illness script in the gout. This will be something like that. Scripts are needed. Even now, many publication offices are doing this. They came to us, they work with us. We have done a lot of digitalization of contents. We have reached a stage where now they have done already mapping of the CDME with the teaching, learning and assessment. You know exactly where the simulated patient details are. You don't have to struggle when you open a LMS. You click on the competency number, you straightaway reach the contents which are there. That will make your life easier because they were showing us LMS which has contents from other countries. Even scenario names were like that. We told them, no, this doesn't look like what we have. Make it more as per India, what we see in the OPDs when 200 patients are there. Okay, not when you have half an hour with one patient. That doesn't happen in India. Some private institutions are doing, but their strategy is entirely different. So this is, for example, boot camp agenda. When you have selected, everything is into it. So you have introduction on that particular day with the selected, which we have done with the 7 of them. Overview of food administrative forms, where to park, employment status, history of other things, what jobs they will do, how they are different. You have to explain them. Okay, then they start acting to that. So script is there. People will then later on, you can rehearse with them that how to act at that. Later on they will activate that. Here are some of the scenarios. This we have done during the COVID time also. Okay, where we went online for the clinical skills also, but using simulated patients. Okay, shoulder dislocation and all those components with the home studio. People were safe in there also, they tried only. At that time was clinical skills, they were not learning at all. Okay, so that happened at that time. This was the OPC scenario where we have replaced the mannequin with the actual person. That happened, and these are examinations where you really pick, and they can actually simulate some of these things which are there. So checklist or grading, there is a debate. You can use both also. Some people use checklist, some grading. Mostly they will combine them. If they have done some advantage, these are examples of some checklists. So you might have seen many things. We are not going into that. So assessment and the feedback, if we have discussed a bit about that, OSCE formative assessment versus these both components as being structured, behavior based, feedback which they will call. Because they know the steps and they know where students have actually missed. Because they were ready with answers. But they are not asked, they are bubbling with to come up with those components. Faculty development programs are treated like this, what we are doing. Writing cases, running scenario, debriefing, training in SP methodology is essential. That's very, very essential. Without that, you just can't put those people into this program. This is informed consent, example of that. Okay. First, you give them some information about that. Resources are also given for that. Some cases are given. Okay. You identify some people, some volunteer is actor is labeled as RK name. Another is SK, so they get their central line infusions or they get blood transfusion they are coming for, and how they will react to the questions. All questions are given to them, possible questions. Okay, so these are case summaries which are built up to that. History of illness is given to them. Okay, so this is how they have to reply. Surgery is none, hospitalization none. So this is all given to them straight. That what would be their answers when this will be answered. Okay. And even so. As I told you, prompts are given to them. They have a prompts that you wait for the student, nothing is coming up, how to go for prompts, and encounter how much time they have to spend on each one. So even patients will give some prompt because they know time is over for this part. Okay, so this keeps on happening. The student format, we are too much into one component. I will share this also. One of the institution has made for the TV, which is very essential for us. So simulated standard patient program for medical students. That the tuberculosis designing a tuberculosis program. This is back very easy again to do. Back people can simulate. So identifying a first scenario, patient profile is important because now they will act like that. So implementation roadmap is phase 1 is planning, and stakeholders should be ready to buy into your concept of this program. Pilot SP sessions do that, piloting rehearsal, which is major. Integration in the curriculum, when you need phase 1, 2, 3, how many you need. Evaluation, after your experience of 1 year, try to scale it up. Okay, that will happen. Some logistics, you already have existing central skill lab in each institution. Okay, so correct your banks and database. Scheduling you need to do at cost planning sustainability is needed to show to your admin that this is beneficial to the institutions. That is very, very important. And now we are coming to last component, which is group activity. We should be able to do it within the time.
Let us break into 3 groups. 3 groups will work and you will prepare a standardized, you will design a standardized patient program for your department or for your institute. Okay, each group will be designing one. You can include components like what are the components in the standardized patient program, blueprinting, recruitment, feedback, and how to sustain the standardized patient program. You will be including all these elements in your program based. Okay, let's make 3 groups. Can you please say 1, 2, 3?
1.
2. 1. 1.
Remember your number.
Yeah. 2.
1.
3.
3.
1. 2. 3. 1.
3.
1.
1.
3. So please gather yourselves into your respective groups.
All the ones at one place, all the
All
twos,
ones, all
all
twos
the
and all threes.
all the ones on the left side.
All ones, please. One of you is needed time. One of you is needed time.
Okay, then history taking components and history taking
Same in the exam.
So questionnaire will be almost always chief complaint. Voided will be in a chronological order. Voided or plus hyperthyroidism or hypothyroidism. How long it is there. Second,
Plus, if it's for the institution, then you will think about how many you need for medicine, how many you need for a year, and how many times in a year. You decide whether it's for UG or PG. We need a program, not for simple. So, for example, how do we get? If you're thinking for
We have developed a design or we have developed a flowchart like this, organograph like thing for developing a standardized patient program for undergraduate training at an institution XYZ. So what we have thought is, initially we need to constitute a standardized patient recruitment committee or a standardized patient bank committee. The SP, BC and SPRC are the short form of that. So who are going to be in this committee is 4 disciplinary members from the academic side, 4 managerial members and 4 extra liaison members are PRs. These will be the ones who will be helping out us to recruit the SPs. Next is campaigning. I'm sorry if my spelling is wrong. So how are we going to do this campaigning? We thought of the snowball technique. Like we will be using the PRs, we will be using the extra liaison peoples like the Lions Club and the other different clubs where we will be selecting, those people will be helping us in recruiting the SPs. These SPs will be detailed about what incentives will be given to them, so that like incentives like having free checkups, getting free blood sampling, or free testing, any procedures which can be done free. So this intensive and the positive part of it will be provided to them, so that they go back to their homes and places where they can spread this by mode of birth and can bring more SPs. So this will be like a snowball technique. Then we will use our advertisements and the social media. Social media is very good nowadays. We can spread anywhere and anyhow. And next will be our recruitment of the SPs. So using all the above, we are going to recruit the SPs according to the age, gender, literacy rate. And initially, what we are going to do when we have quarterly meetings with the SBDC, that is the Standardized Patient Recruitment Committee, where the departments will be deciding how many SPs they are going to require for these many numbers of students. For example, if they have an intake of 100 students and in the final year part 2 they want to have some topic to be discussed. For example, we are thinking of the thyroid, where the students can go about asking the communication, the history taking part, the examination part. We ask the Department of ENT or Surgery that how many SPs are required per a period of learner doctor hours, the number of hours. So taking the requirements from each department, we are going to allot SP. Next, how are these SPs going to be trained? So here again we are going to, the departments, individual departments will develop the scripts, develop the protocols, give it to they will provide it to the committee as well as to the persons who are going to be training them. They will create blueprints for that particular year or the number of hours which are being allotted. So the script preparation and the blueprints, we are going to use individual departments input, and what skills and what competencies are they going to use it for teaching learning method, is it for assessment, and definitely for each and every round we are going to take the feedback. Last but not the least, we are including sustainability, how this program will be sustaining in the institution. For that, again we are going to take all the stakeholder feedback from the student, from the department, from all the liaisons and from all the parts of the way. And this feedback will be given to the quality control and the quality assurance part of it. And the same process will be repeated. Whatever mistakes have been done, I don't say mistake, whatever loopholes have been there, those will be again reiterated, and the loopholes shall be filled. Thank you.
Any comments, questions, queries from group 2 and 3?
Daily for one particular department, how would you do it? What kind of scenario you select? What kind of training you do? But I think overall they have given a good framework for an institution how to go about it.
Right. Thank you, sir. Anyone?
Two facets. One, the need for the SPs being in medical education being properly defined and explained, elaborated to the original committee members, just like ethics committee for the studies, the recruiting of the members. The members will include kind of personalities who will be providing resources as well as ability to campaign and recruit different members. So the feasibility is there because we are getting the need as well as the expertise to execute over a period of the 1 year divided into 4 quarters. The review is done every quarterly with inputs from the administration principal if it is happening thoroughly, properly, in line or not. So feasibility is because we are ensuring resources and also getting the viability point and the need by the institution that it is proceeding well. So
As sir told that you have given an overall
overall
structure of the program, not the details of that how many you need. More appropriate if you get, okay, we need 4 SPs here, we need 5 here, and they will come for 7 times or 8 times. And we think in our institution that is possible, and we need this much of money, and that is also possible under a similar schedule, something like that. Then we will think it's a feasibility. Otherwise, they are giving you overview again that okay, we have this and this and that.
Administrators point of view, they want some profit.
How you will convince administrators for
it will generate surplus. That's the model.
how you will convince administrators that you want to run this course, this program in your institution?
So the resource will be by the alumni and patrons and well-wishers, for those who are concerned about better doctors and better society and less stress-free medical education.
So here is about one resource, alumni is very strong, so they will fund this program initially.
So surplus will be, because after spending on all these things, surplus will be there, awards, patrons, all those things will have celebrated.
Recognition of the people who have contributed to the success of this program.
Try to get more sponsors.
Good SPS means good fee structure of the students.
Good or unfeasible, that will question the that is not feasible. If you are putting extra burden on the resources, then usually program fail. You try to adjust within the central scale budget. Most of you have bought the mannequins, that part is over. Now the next budget should be for training and for programs. Okay? And in this program, you don't have to buy mannequins actually. You have to just train people and recruit people.
This NMC made it mandatory. It's very difficult to convince everyone.
That question we get many times. Why you are not giving yellows? Why you are not making a mandatory? So many things have been made mandatory.
One of the good example is in actually to read Mahalakshmi's paper in Balaji, and you see her experience. She has really done it well, where she convinced her kind of funders to use NGOs and women, and she only pays some 50 rupees per day to them. These people come, they get treatment also, at the same time they get that honor that we are helping medical students to learn. A wonderful model she created, and the resources they spend is not very much. It's about say a few thousand rupees per year. And I think if you convince the management that instead of really spending too many things on mannequins, if you pay this much, this is a better experience for this. And that model has worked very well for last 3-4 years, 5 years I think. So these are the some things which you can learn, you know. I think it will take time for convincing management, but if you tell them that this is going to help the quality of your students' learning, they probably will agree to for the small amount of funding. I'm sure it's not a large amount of funding.
So, very right, not having so many patient material, but we have to teach our students how we do that. So this is one answer to that. Create a need, then funding will automatically come from now the budget of the skill labs which you are not using for the mannequins. So you can say actually we can place. In fact, I will say other ways. NMC has not made mandatory how many mannequins. So use this clause there. Use patients, simulated patients. You don't have to buy plastic for everything. So teaching can be, learning can be more real here, more simulated. So invest here. That sort of discussion, what happened here. In between you see what is the phantom mind of your admin. It's money, social accountability, pick up that and hit on that. So जो $1 वाला hit करना ना वो पहचान लो फिर then you do that. Thank you so much. We'll go to group 2 now. Group 1.
You should check out the resources of funding in creating a mob which is coming hugely at a time. Initial examining the patient and how to have the interprofessional teamwork. So blueprint should contain case 1 is how to control the mob. Case 2 is communication with the patient attenders. Case 3 is testing the clinical skills to the patient who is in pain. Case 4, how to have the teamwork to attending the case. Case 5 is breaking a bad news if at all necessary. Then recruiting, we can use NGOs as sir has already suggested. NGOs or volunteers, security professional, simulating patients, internal staff and students in creating the mob atmosphere and the patient. And feedback will be taken once weekly, and we can sustain it by training the nurses, nursing staff and all the others who actually require that such kind of treatments. Technical persons, nursing.
So you have prescribed the program for the interns for the emergency scenario.
I'm not comparing it, but what I felt is like we have given a overall outline of how the institute is going to recruit the SP. They have included a part of how they are going to. So I felt the flowchart which we have got, that part came into the recruitment and the training part of it, where the departments are taking the active.
Components are common if you think, but here they have looked at interns training program, and specifically you have chosen a field for the emergency scenarios.
I tremendously appreciate Group 2 for identifying and highlighting a very pressing causing apprehension within medical fraternity, right at the level of becoming a doctor. So the benefit of the whatever program module will develop will be lifelong and will have multiplier effect. So I appreciate members for highlighting their topic. If somebody else anytime we may join, you may do something like that.
So, if sir is your principal, you will immediately get funding. This is the way to convince. Pick up the point which you know your admin, which is important. For him, for example, this scenario is a very important. I mean, just a scenario for our MBBS students. You know your administration, you know your point of view. Pick up that point and start a program from internals. You show them result. Next year you say, sir, we want to extend it to part 1 and part 2 also. That is the feasibility, acceptability which will come into play. So thank you so much. So that is any comments to make? Yes, sir.
Definitely an excellent point which society needs now. Train them all the medical students on mob control and emergency control. That the legal problems we can take. Most doctors also don't know how to pay. They will avoid and push to juniors, something like that. So that responsibility, everything, definitely the planning and implementing and sustaining is going to help the society.
Very right, sir. And you know this is a common feedback you will get from your admin. Please train our JRs, SRs. They are the front force. Many times they are beaten up in that because they are not communicating. They are not. So train them. This your administration will come saying many times. Please tell them how to talk. Tell JR and SR how to talk. Just how to talk. So that will improve these situations when the mob is there. Thank you so much. Good thing. It's your turn now. You were waiting for that. Yes.
Actually, we have prepared a program for the general medicine department, and we want to find the students in history and taking a technical examination for the inpatient skills. And our department will get the second year, third year part 1 and third year part 2 students. So, and we have discussed about the number of classes per month, how many times they will come. So, how many SPs we may require, how frequently we require, and those things. And the attempts also, at least 2 or 3 attempts for each skill. So at least we need 10 SPs we need, and we have to spend more time on the first training. And at least 5 times in a month they should come to the department. That's what we thought. The next one is regarding the recruitment of the patients. Regarding the recruitment of the patients, and I feel that we won't go for the social media or other things campaign because socially certain things are not acceptable as of now. If some colleges trying to students like this, if the community knows, it won't look nice. As of now, it won't look nice. Maybe for the educators it is okay. Maybe for the trainers and other people, primarily depend upon the ex-employees, retired technicians and post-class employees. And the main other things, we will get primarily funding is from the central level funding. And because these people are very much part of the system, so it's easy to recruit them, and also funding will be reasonable. The training within the department, we have to prepare the scripts, and it has to be tested, and feedback has to be taken both from the SPs and also from the students for the correction of the things.
Thank you. Input from group 1 and 2.
Backfire completely. But validity is that any communication, anything related to health, medicine, medical education is very emotional to the entire society. So in the campaigning points, there should be that kind of balance that if something is misunderstood or things like that, trolling happens to the program or the institution, there is enough of defense to manage it. So campaigning requires backup steps also if there is a misunderstanding. So that will cover. I think what he mentioned complements what what we thought about. It makes the alertness even more better, and the programs will be better. Any other program. It's a good point.
Also, as you both highlighted, I will bring out your cultural competence.
That's good.
which means first point is cultural awareness. You are aware of the culture around you. Second is culture sensitivity. Then you act accordingly. You are very right. You have assessed that in your setup it is not appropriate. You think in your setup it is appropriate. You go accordingly. This is cultural competence. You have to decide about that. Because, for example, if you advertise that you are simulating drug addiction behavior, you are paying also, you might have many drug addicts landing up. Because you are paying also. They are ready to go everywhere. Okay, so that things you need to take into account. So that's very good. Any other comments?
Feedback from SPs also. We need to know what the feeling like.
About the program, that program, how it can be improved, and their own issues which they have had through that to improve your program for the next time. So that can be also part of that. Although we did not plan like that, they have started with the overall structuring. They have put up an internship program into that and convinced the team very well. And they have come into more details, number of SPs which are needed. And they went into details about the headings of that examination. They know so much. So this is what we are talking about at institutional level. Maybe that is also at institutional level. Here they are coming at department level. How you can build up. Some things are common.
Feedback from SPs.
You build up your blueprinting and assessment. Assessment is a state subject to be handled by the university. Yes. Only thing is NMC gives you marks. These are the marks. Rest of the thing you have to do at the university level. So you decide who are the brain sitting in the board of studies. You decide what you want, but put it there so that everyone knows this has to be done as well. Then you will have not that problem. NMC has not given that. Okay, so this is the state subject. Assessment is given assessment. You plan your blueprinting, add into that. Okay, we can use 360 the feedback. Earlier one question which came during the tea break also that for actors, you need to actually find actors also. In your institution, you can use your department technicians, nursing staff, other people also who can come as simulator patients. They are dedicated, they are working, they will be paid also for that. You can build up that also. That's a very good model. Actually, definition was they are not patients, they are normal people who are acting like that. So you can very well take them into that
Even the academic wise also good idea.
Consensus, have a brainstorming in your institution or university, you have a consensus and start using that. Yes. People were asking us before CBME, and she has not told us it is asking to be done mandatory. People are doing for 20 years. They do not, you total have flexibility for using teaching learning method and assessment. You even see the column, it says suggested teaching learning method, suggested assessment methods. You are more trained, you can innovate, please use that. There is nothing, no bar. Last part we are coming to that. 2-3 minutes. Offer an admin post. Since it is affecting your other things, they will compensate financially to you. Okay? So they have started that way. Since you are principal or dean for that group, you can start that. So the challenges of many different aspects are available. It's not last moment you are selling that. Your university is deciding practical dates very late. You come to know very late. So those things should not happen. So one of the approaches when we do these things is the partners create a sense of urgency. We need that, build a guiding coalition and form a strategic vision and initiatives. This is the first step. Then getting going is enlist a voluntary army who are ready to help your institutions. Remove barriers to enable this action. Wherever you find the resistance will come, identify. And then gaining momentum, generate short-term wins, sustain. Look for short-term wins initially. Low-hanging fruits. They are easier to pick up and show to others. And we say, okay, see, this is working, this is working. Then go for sustained realization, and then you will have this institutional change. You will find out partners anywhere. This you might have seen many places. Where you place your dean and all for this program, so you can actually look at the key influencer. But remember that in your confusion of program which you have, you should not have something like this. Okay? Which you have conceptualized, but when it comes out, it is entirely different thing. So that has happened, we have seen that has happened with SDL, we have seen that has happened with the London doctor method. If you don't know the methodology, first try to get into hands into correct methodology and then prepare something. Maintaining realism, ongoing changes, we are getting up and up into the you can build. So with that, I think system, for example, you know already somebody has made a script, but that is in the northern India, but you need to balance it in your setup. People react differently, behave differently, you need to balance. It's like for any other method.
Can I comment?
Yes, sir, please.
At times there was a question was, we have so many patients, why do we really need it?
Exactly.
And we tend to always discard that this is not a very good modality. But now after 20 years, I think there is now a role for standardized or simulated patients in our curriculum. So the question is, we are now changing our minds. So we need to think about which areas we can develop a small program to begin with, use it for teaching, learning, validate it, then put it into assessment program. I think that small change is coming. And I think it's a mental change which will help us to really use it appropriately for particular skills which we cannot give in our regular program or in the skill lab. I think it's a small niche, but we need to develop it. And I think for that is something where we should use it. And second is to customize it to our Indian needs. We cannot pay so much to the actors. So we use local people, we train our staff, students, and the message has to go. So the literature is coming slowly in this particular field. And I think we need to form a group, develop, share, and how to integrate these programs into our day-to-day life. So these are some of the challenges we should really look, and we should take this further.
Thank you.
So very nicely done. I must really tell you, Dinesh, very well conducted.
Thank you.
Exam simulated.
Many people are already using it. They have used it.
Ask you,
People are using it. Yes, sir. I have seen people external examination on the day of that NFC session also happening. It's a regular thing. There's nothing like NFC doesn't accept an assessment. They look only at marks, you are following that. It's okay.
They are asking you to know the programmers.
So I come to that. They make you make OSCE. How many people are actually doing OSCE? Sir, remember, sir, we are telling people to use OSCE for the last 3 decades. Nobody was using. One notice came, Form 6. Form C and video, 800 medical colleges in India are doing OSCE. Can you imagine? Have you seen that videos? They put everything in one lecture hall. In the PPT, one photo counts. Everyone has to write the answer. That is OSCE. No, most of them. So, but in the process, they got aware what is OSCE. Now they are learning. Even and some institutions are doing OSCE for the last 2 decades. So there's nothing NMC or MCA preventing you. It's only marks they have given, rest is up to you. You innovate more, you have more resources, you have simulated patient, do it. No issues. And sir, what sir said over and above, you have now availability of centralized. Use them also for that. That will make things happening. So central skill labs took 4 or 5 years to make. So maybe simulated patient, another 4 or 5 years. Basic will be coming up. It's coming up in a big way. People are using it. I've seen MD exams happening, MD medicine happening with the simulated patients. That's doable, feasible, is something. So we hand over to the organizers, Manswani and team.
Sir, to give me the certificate and we go to Dr. Dinesh K Badyal, sir. We request Dr. Agnes. Dr. V. Nageshwar Rao, sir. Dr. P. Rajesh, sir. Dr. Niharika Balla, ma'am.
And we are done.
ఓకేనా మేడం ప్లీజ్ more
Thank you so much. Big round of applause.